say a very great thank you to the Nepal Radiologists Association for the kind invitation to speak at this meeting. So today I'll be sharing with you a little bit about my own journey and what we have been implementing in AI in the field of nuclear medicine in Singapore General Hospital. I mean, I've given this presentation before, and essentially, I mean, if you look at AI in the field of nuclear medicine, I think there were a few actually reviews by some of our major nuclear medicine societies discussing how, oh, actually a lot of the images seem to be missing from this. Discussing how actually nuclear medicine seems to be lagging behind. If you look at, I'm a radiologist by training first before I did nuclear medicine. And in the field of deploying AI in nuclear medicine, I think radiology has really gone ahead. You have seen the presentation earlier by the speaker just before me talking about AI in breast imaging. And actually, if you look at breast imaging, we know that actually computer-aided detection has been around in breast way before a lot of the other sections have actually adopted AI. And in the same way, nuclear medicine, a lot of times we just sort of assume that because, for example, PET-CT, the CT part of it is done very similar to radiology. So maybe the algorithms that are being developed for radiology will also just work for nuclear medicine. But actually, nuclear medicine is a lot broader than that, because beyond the diagnostic part, there's also the therapeutic part, as well as clinics, though actually nowadays in IR, we do see quite a lot of the IR doctors also running clinics. So there are different aspects to AI that we can use. I don't know, are you able to recover the slides? Do you need me to do something? 2 minutes? Okay, sure, no worries. Sorry for the issues with that. Oh, okay.
Dr. Charles,
yeah.
So if I may, so since when have you been using this AI in Singapore in your imaging?
Okay, so actually, I think if you look at AI in terms of its sort of availability and deployment in different places, there are different levels of AI, there are different types of AI that we have been trying to use. I think for quite a number of years, I think people have been looking at interpretive AI. What was shared just now also in terms of, besides the old computer-aided detection in terms of mammography, but newer AI techniques. These are things that we have been looking into for a while, but more recently, I think everywhere, since a few years back when ChatGPT burst onto the scene, a lot of us have been actually trying other kinds of AI, not just looking at image interpretation, but also in terms of large language models, how we can use them to streamline our reporting, or even sometimes our communications, even research aspects.
Yeah, it was many years that physicians, doctors were involved in training model, creating a model and training the model. Now gradually they are shifting towards implementing those in the population.
Yeah. I think one of the biggest things right now is that actually there have been a lot of models that have been around for quite a while already. And more and more models is not what we need. Actually, what we have been finding is that the bigger issue is how are we integrating those models into our clinical workflows? Because radiologists don't have time. For example, I think in my institution, they had a few models for chest X-ray, and the results, when on paper, very good, sensitivity, specificity, very high, but nobody's using it, and we ask why. And then people tell you that if I take a minute to report an X-ray, but your AI model takes 2 minutes to run, I'm not going to use your model. So we have to realize that the AI models, you're not just looking at how accurate it is, how sensitive, how specific, but is it really well integrated into your workflow? So in Singapore, for example, I have the opportunity to speak in my role in the Singapore Radiological Society, speak to many people who are actually in private side who have implemented. And a lot of it is about reducing the amount of friction or difficulty for radiologists to actually access the model. So, for example, in terms of chest X-ray reports, some of them have been sending the AI in some of the centers that I know, sending the AI outputs directly into PACS as a secondary capture. But there are some issues with that as well. I think there were some concerns that if we do that, then the clinicians also have access to those outputs before a radiologist has a chance to review it. So I think when we are thinking about how to make it more streamlined, how to make it work better, we actually have to be very, very clear about who is who is responsible. A lot of the liability issues are actually very, very important. And from the radiology side, we have to control it because honestly speaking, there's a lot of worry. I'm sure that many of you in the room are also worried. There's a lot of worry, the clinicians trying to just take the radiologists out of the picture, right? And I think that we have to be very clear about the value that we bring in. And we have to be very clear that actually there are issues. Just now the previous speaker was also talking about AI missing cancer. And we know that actually the AI models, even if they say 80%, 90% accurate, right? The 10% or that 5 to 10% where they make errors, AI tends to make errors in a different way than humans make errors. I mean, we all know that, for example, our residents make errors or we make errors because we miss things because of our inability to maybe you're tired or you're inattention, you miss things. But the way that humans fail is very different from the way that AI fails. If any of you have worked with ChatGPT or anything like that, if you have used some of these large language models, you know sometimes AI will just tell you something. It sounds very, very convincing. 100% it knows that it's correct, but actually it's completely wrong. The references are completely wrong. The data is completely wrong. There's actually no value in that. And that's the worry. The difficulty is that for us, when clinicians work with us, if we're not sure about something, they already know. You write a lot of things, indeterminate, clinical correlation. People know that you have doubt. But I think that when we look at AI models, there are a lot of tools right now and ways, explainability. Just now they also showed in terms of those green and those red areas, where are the areas of attention that the AI model has? That's number one. Some of them even nowadays have confidence scores. So I think we need a lot of these kind of things with our AI before we can trust it, before we can deploy it. I'll just dive right into it. I know time is late. I know there's dinner later. I'll just quickly go through. If you look at all the FDA-approved models, there are more than 1,000 now, and more than 75% of them are actually in radiology. So we know that AI research is really hot in radiology, and it's not just interpretive, it's all the non-interpretive things as well. So when we look at AI processes in nuclear medicine, okay, this didn't really work out that well, but if you look, actually, there are a number of processes that are in radiology, the diagnostic part, but like I mentioned, for nuclear medicine, we also have other things like treatment planning, therapy, and all of these things all can have AI models that aid it. So everything from when you look before you start doing the scan, in terms of ordering and scheduling, are you using clinical decision support? Is there auto-scheduling? How about protocoling? Those things can also be augmented by AI. Scanning, in terms of positioning and acquisition, radiology side is also doing that. All the different CATs, in terms of triage, detection, diagnosis. How about for report summarization? It's something that we've been looking at as well. Because we write reports for our clinicians, but when the patients see it, they don't understand at all. Nowadays, you can throw the whole thing into a large language model and can produce something that a layperson can understand. Then for the nuclear medicine side, we have all these things like dosimetry, ambient documentation when you're doing consults. So I'll just go over some of it today. I think one area that has been advancing quite rapidly is in terms of denoising and image reconstruction. We see that in radiology side. So, my partners over at the radiology department, we look into things like subtle MR, looking at MR signals and how we can improve that. From the PET side of it, since the early days, we've been working on our reconstruction algorithms with different newer algorithms to denoise. But now, besides the traditional methods, we are looking into things like neural networks that either work on the constructed image already, or now even more, we can work on just the direct, the raw data, and you can combine different methods, classical methods like expectation maximization with neural networks, and that allows you to reduce tracer dose, reduce imaging time while improving image quality. Some of the research that has gone into it is actually quite remarkable. So this is one study that was published looking at some of the newer transformer models that actually can improve the signal-to-noise ratio and improve the overall amount of signal. And what they looked at was seeing if you use these methods, how much dose can you actually reduce? For us in nuclear medicine, dose and time are interchangeable. You image somebody twice as long, you can use half the dose. If you want to image them shorter, you can give a higher dose. But some of these techniques actually allow us to produce clinically usable data at a reduction of 90% of the dose. That means the tracer, which costs money, or actually the scan time. You can reduce the scan time by up to 90%. But one thing to watch out for is that even in this study, and a number of studies are coming out right now, the AI techniques for reconstruction sometimes produce imaging artifacts, especially when you accelerate too much. So I think we have seen this in the radiology side, but we are also on the nuclear medicine side a little bit cautious. Right now, I think people are looking at similar image quality clinically with about 25% to 50% dose reduction, which really improves the clinical reliability and the speed of our imaging and cost as well. Another thing that we have been looking at in our institution, there were a number of publications looking at segmentation. So being able to produce newer metrics like total metabolic tumor volume instead of just SUV max. To do this by hand right now is very tedious, so there are automated methods. And this study that was published actually looked at and compared a human segmentation versus the AI segmentation, and they rated it either via the DICE score, which measures the sort of correlation, or via human readers. And they showed actually quite good results. I mean, the DICE scores were about if I'm not wrong, as good as more than 0.6 to 0.7. So we looked at it, we thought it was quite good. We wanted to try it out because published, it looks quite good. But as with all things, when we try out things that are published in our own institution, it doesn't always work out that well. So for our implementation, we did 65 PET scans, and we found that actually the metrics look quite good. DICE score means the correlation about 0.782 and able to exclude a lot of the physiological sites that are not disease. But it had some difficulties, some problems with large lesions and had some blind spots. So this is what I mean. With the large lesions like this, one part of it is segmented and half of it is not. And if you ask any human to do this, nobody would do this. But you realize that this is the kind of problem, this is the reason why we still need humans to check the work of the AI in that sense. Also, there were blind spots in things like marrow, where most experienced readers would not miss their spots of disease inside the bone, but it was missed by the AI. Other areas we've been looking at, things like dosimetry. So when we do our Y90 planning for liver treatments, it usually used to take our technicians about 1 hour per case, but now with the automated dose calculations, they save a lot of time in case, just automatically segmenting and then redrawing it. So for each case, it may take only about 5 to 10 minutes for them to be able to complete it. So a lot of time savings for our technicians. As I mentioned just now, I think one of the big areas in which we've been exploring, and the reason why there's been a lot of advancement, is that people without any experience in coding or programming can use the large language models. So our government actually built 2 models to be used specifically for our healthcare data. It's not public models in that sense. It's shared only within our intranet network using what we call pair and tandem, which are built in combination with Microsoft as well. And there were many, many use cases that we have actually tried out. So things like retrieval augmented generation, which actually allows you to put in our policies, put in our guidelines, and then the results are not just going to be taken out from nowhere or the internet, but actually based on guidelines. Things like report summarization, formatting, educational things like preparing questions, and note-taking and documentation. So I'll just highlight 2 of the use cases that came out of this. So one of them was in terms of lymphoma report summarization. This was actually what I shared earlier on in January at a different meeting, but we've actually since come a bit further from there. So we actually put in our lymphoma reports and tried to extract features that they're using for research. So things like the size of lesions, how much FDG uptake, and the current stage. And at that point in time, actually, some things were quite good, like the Deauville score came out quite nice, but the sites of disease and the stage actually not really very good. There were some issues with the model. So what they did actually, they used a combined, we worked with our technicians to work with what we call prompt engineering. So we actually put it through 2 different large language models. The first one to do a summarization, and the second one is to actually do more the feature extraction and then summarization. So we start with our base report. They run it through one large language model to extract some features, and then they run it through a second large language model with prompt engineering to determine things like the stage, things like whether these sites are extranodal or nodal, and then finally to give a total overall staging and scoring for that. So that's worked out quite well, and right now with our current, and the iteration of all this is very fast. There have actually been multiple iterations, and now it's actually been deployed as of just 2 weeks ago into our research setting because the results are now very, very close to 1. But I would say, meaning 100% accurate in these specific metrics. We don't really want to use it for clinical yet because for us, that 4 to 5% of inaccuracy could be really problematic. We still need somebody to check it for clinical, but for research, it's actually better than what we had, which was just an admin assistant. One of the other things that we're using these large language models that we have is we also have an ambient scribe. So what is an ambient scribe? is when the doctor and patient talk, and they take the verbal consultation from the microphone and they put it into a structured clinical note. So we actually deployed it across our whole hospital. We have about 2,800 users, and this was set at the end of last year, we have about 30,000 notes. It's actually multilingual, so our society uses English, Mandarin, Malay, Tamil, Cantonese, and all of these languages can be used. And we thought that it would save time for consult, but the truth is it turned out it didn't save time. The consults are just as long as before, but the patients and the doctors are happier about it. So if you look at the consult duration, actually, oddly enough, with the Note Buddy, with this model, actually a little bit longer on average. Maybe they just talk more because they enjoy it. But better eye contact, lower documentation time, and also better patient experience with this. So I'll just quickly show what it looks like. In our society, sometimes people will be talking in English, but halfway through they suddenly speak in Mandarin, and the model can do that. It can switch languages, and it takes verbatim, whatever people are saying, and it formats it in a medical way, in a way that we can put it directly into our notes. So that's been quite time-saving and actually helps to reduce burnout among our clinicians. I talked a little bit about this just now, but I think right now we are moving past the stage where we are talking about more and better algorithms. If we want better clinical adoption, it's not just about accuracy, which is the performance, but it's about trust. How much can we trust the models? Is it explainable? Are we able to determine how the AI made its decisions? How easy is it to use? How fast is it? Do you have to click open a different browser or something, or is it integrated right into your workflow? And finally, one of the most tricky questions that our chief financial officer always asks us, how about the return on investment? This is a very tricky thing, because he said, if we use AI, can we fire some radiologists? The answer is usually no. If you use AI, can you report more cases? Most of the radiologists don't want to. So that's the question that we really have to ask ourselves. If we pay money for AI, are we going to get return on investment? And that's the only way that our hospitals are going to adopt it at scale. I think in our hospital, we've asked ourselves, when we deploy AI, what kind of ethical principles are we going to use to govern it? Is it going to be safe? Is it fair? Is it transparent? Is it explainable? So do you know how the AI works? How robust is the AI? Does it perform well in different conditions? How about security and data protection? Will your AI leak your data, to other people? And ultimately, AI needs to be aligned to our human goals. It's not about finding out what the tech can do and then doing whatever the tech can do, but it's about how the tech enables us to do what we want to do as doctors, as patients, as human beings. Is it enabling us to do the right thing? And for us, right now, we are still working out our full governance model, but it's risk-based, it's tiered, and essentially for the model, we are looking at, is it fully automated? Is it partially automated, a human in the loop? Or is it entirely under manual control? So somebody actually has to oversee the whole thing. And the more supervision, then the lower risk we have deemed it to be. Also, we are now much more willing to deploy AI models in administration. Doesn't have to be as robustly tested compared to patient care. And let alone a model like they were saying just now, AI for memo reads without any oversight. Who's going to take responsibility for that? I think that is a real question we have to ask ourselves. Different levels of risk, different levels of oversight are required, and so that's what we are working out right now in real time, actually. How often do the models need to be reviewed? Because there's a risk of things like a model drift or other things like that as well. So I don't want to take up more time. I know it's very late already. In summary, we all see it. There's a rapid adoption of AI in healthcare. But despite that, we still need to make sure that we don't just deploy models directly off the shelf. We need to locally validate and test our models, because as I showed you earlier, some of the models that reportedly do very well, they don't do well in our environment for whatever reason. It might be technological, it might be our patient factors, etc. When we pick use cases, we should try to generate value. It's not just about deploying an AI model so that we can tell everybody we're using AI, but is it really valuable to our patients, our clinicians? Is it valuable to us in our practice? Governance needs to be implemented, and we need to think very, very carefully about how we can do it in a way that's sustainable. So just want to acknowledge all the different groups that have worked with me on this, and invite all of you to come to Singapore in August for our meeting. We are running the Asian Oceanian Congress of Radiology, 20th to 23rd August. So do come and join us. Thank you very much for your time.